Dear colleagues, dear friends, distinguished speakers, good morning, everyone. It's a new, nice, fantastic Congress Pharmacy Day, and welcome to the plenary session of Technology to Strengthen Health Systems, Challenges, Opportunities, and Sustainable Solutions. In an age where technological advancements are actually shaping the very fabric of our societies, the integration of technology within healthcare systems and pharmacy holds immense promise and potential. And this session is dedicated to the comprehensive exploration of the intricate interplay between technology and health systems as we navigate the challenges, seize the opportunities, and as we chart a course towards sustainable solutions. My name is Lars-Åke Söderlund. I am one of the vice presidents of FIP and also co-chair of the FIP Technology Advisory Group. It is indeed a great honor to see so many of you here this morning, and it's a special honor for me and pleasure to co-chairing this session with my colleague and friend, Professor Ralph Altier, the chair of the FIP Education Initiative, FIP-Ed, and Professor Altier is from USA. I would also like to give a warm welcome to our distinguished speakers and experts with us today, Dr. Vin Gupta, Amazon, United States, Mr. Sean Damasen, and Dr. John Nailigira from Rwanda National Pharmacy Council. Actually, both the names are John, but one is in French and one is in English. And Professor Chris Bain from the Monash University, Australia. Thank you all for being with us today. Health systems worldwide are under unprecedented pressure to adapt, innovate, and provide accessible, high-quality healthcare. And technology, ranging from digital health records to telemedicine platforms, artificial intelligence to remote monitoring solutions, emerges as a formidable ally in addressing those demands. And of course, however, as we embrace the transformative capabilities of technology, we are also confronted by a series of challenges, from interoperability concerns and data privacy issues to equitable access and digital literacy. Our plenary session is a collective endeavor to dissect these multifaceted aspects, and we have assembled a panel of renowned experts and thought leaders, each contributing a unique perspective on how technology can actually drive positive change within our health systems and pharmacy. So now, Ralph, over to you.
Thank you, Lars. So we'll take a little bit of detour here before we get to our speakers, because there's some housekeeping issues that we need to attend to. I assume we have no conflicts of interest. Is this correct?
No, the speakers can announce that if they have any conflicts of interest.
Got it. Okay, so we like to evaluate all of our sessions, so please download the app, and you can enter the event code, FIP Brisbane 2023, and give us an evaluation. We use these in the programming committee so that we can improve each Congress from one year to the next. So we would appreciate your input on that. We're going to reserve a little bit of time at the end for a panel discussion, so we're going to ask for you to hold all your questions until the end. We'll have about 10, 12 minutes or so for a panel discussion and Q&A session. I'm not sure that if you have your booklets, you have a yes and no, but I'm not sure we'll get to that.
No.
I'd like to see all yeses at the end. Did you like the session? Yes. Again, for the slides, remind you that there is no recording of the sessions allowed. You may not download the speaker slides at the end of the session. These will become available to you after the Congress. In October is what the plan is. And we'll send it to you for your email address for your registration. Again, we'd like to get out the word of what's going on at FIP Congresses, so ask you to get on your social media and share your thoughts on this with your groups. Again, please take any things you've brought in here, You know, it's like being in the wilderness. The only thing you leave behind are your footprints. And so we'd ask you that so we can refresh this room for the next session. Invite you to come and visit the FIP booth and learn more about FIP and our programs. And so if you want more information on this book or ordering this book on pharmaceutical care and the digital revolution, please contact Carola at fip.org at the bottom of that slide, very easy to remember. And I'll turn it back over to Lars.
Thank you. Thank you so much, Ralph. And also regarding the book, I think it's a prerequisite for every faculty of pharmacy nowadays to include digital health in the curriculum. It is now a great honor and pleasure to introduce the first speaker, Dr. Vin Gupta. Dr. Vin Gupta is a pulmonologist and Air Force veteran. He is the Chief Medical Officer for Amazon Pharmacy. He was hired by Amazon in January of 2020 and is helping lead the company's effort to grow its presence in healthcare. Described as the most widely recognized medical expert, Dr. Vin Gupta is a tech visionary who operates at the heart of disruption to develop solutions to the most complex challenges in commerce, communication, healthcare, and society, now and in the future. And close to 2 decades of experience as a renowned health policy expert and clinician have led Dr. Gupta to his current role as Chief Medical Officer at Amazon Pharmacy, where he spearheads cutting-edge programs that are leading us into the interdependent future of healthcare and technology. A uniquely public-facing person keeping the world in the now, uniquely, and also about what's happening now and in the next. And Dr. Gupta's forward-looking insights inspire leaders and their organizations to embrace change, think outside the box, to break new ground, and create new inroads to innovation and success. Please join me in a round of applause welcoming Dr. Gupta to the stage.
Good morning, everybody. It's really great to be here. True honor. To be here in Brisbane for the very first time. And you know, I don't have the full 30-minute slate because we're trying to create room for a panel discussion at the end. So I'm going to kick it right off and get to the heart of what I'm hoping we can talk about today, which is reimagining the pharmacy experience, first in the United States. Getting conflicts just out of the way up front. And then now setting context. As Lars mentioned, and thank you for that kind introduction, I have to say this is just it's a real honor to be here in front of a global community of healthcare experts to talk about our shared vision for the future of pharmacy and care delivery. I did want to start off here with setting some context, and I think some of these statistics are not going to be uncommon or unfamiliar to many of you in this room. And this is not US-centric. We know that by the end of the decade, we're going to have the oldest society on record in many parts of the world. Certainly in Western economies, but this is not just limited to Western economies. I will say in the United States, we spend an outsized excess of our GDP on healthcare. And we're more data-driven, more digitized than we've ever been. I've been a part of a few I've joined some of the other sessions earlier this week. Yesterday in particular, I was hearing about the convergence of some of these themes, especially in an era where I know our politics often enters in some interesting dynamics later on top of these trend lines. But the future is uncertain. We have increased demand for healthcare services and these numbers here are what we're seeing across the United States, a decreased supply of individuals that can actually administer the care that's needed. Whether it's pharmacists, whether it's physicians, whether it's nurses. We do not have in our pipeline enough people to care for those that are in need. And so when I hear about issues that are raised in this international forum, issues of pharmacy scope of practice, yesterday a great panel discussion on pharmacists as vaccinators. Frankly, I just think that's the tip of the spear. Yes, that's one thing they can do well. They can do a lot well. At Amazon Pharmacy, I'll talk about this in just a bit, we have our pharmacists actually engaged in clinical care, medication therapeutic management. understanding when you can de-escalate an individual who might be on multiple medications from one of those medications, being a true part of the care team, leaning into their clinical expertise. Why does that matter? It matters because of this set of realities. It matters because by the end of the decade, again, we're going to be facing a supply-demand mismatch. Oldest society on record, more needs, more information at individual patients' fingertips, less people to actually meet that need. We need pharmacists to help fill that void. And I think we've, as a broader healthcare continuum, not done enough to advocate for that. That's why FIP, frankly, is so important to organize us, to be able to share these advocacy themes, to figure out what exactly is best practices here. But it's with that context, where we're headed, all these convergence points, these statistics on supply-demand mismatch that bring me here today to talk about what we're doing at Amazon Health. I'm a clinically active pulmonologist. I still see patients about 30% of my time, and what I see in the four walls of a traditional hospital setting in the United States is, again, everything that I just told you. That we have ICUs and emergency rooms that are uniquely vulnerable to that next healthcare crisis. I was deployed as part of the US Air Force multiple times over the last 3 years because our response to a crisis, at least in the US, was to deploy the military. When ERs and urgent care facilities were swamped, that was our response. And we often saw, actually, a very interesting debate emerge over the last 36 months that I think the lay public now has actually understood, is passionate about to a certain degree, which is, gosh, pharmacists can actually help close the gap. Maybe if we allow pharmacists to do more, we can protect those urgent care clinics. We can protect the ICU. And so what are we doing at Amazon? You know, we recognize that there's this supply-demand mismatch. We recognize that there's a massive opportunity to bring a customer-centric viewpoint to how we deliver a pharmacy experience that meets patients where they want to be met. I can't tell you how many times my patient with emphysema or asthma says, you know what, doc, can you prescribe a medication that can just be delivered via a pharmacy that will deliver right to my doorstep? Do I actually have to go and drive in and pick up the medication? Or can you tell me how much I'm going to have to pay for that medication? I'm tired of getting a surprise bill at the pharmacy counter. Again, I'm giving you at least the experience of several patients in the US that I know might look a little different based on your specific context. But there is no longer patience for something that is unacceptable. Lack of price transparency, a difficult retail pharmacy experience for many patients. They have to drive, in some cases, a few hours to pick up their medications. The pandemic has fundamentally changed things. So we think, leaning into our retail roots as broader Amazon, that we have a set of services here that actually can help reimagine the pharmacy experience, that can promote a more engaging experience for patients, that can hopefully help them stay on their medications. Because at least in the United States, one of the big problems here that we're solving for is medication non-adherence. $300 billion in attendant costs just because people and patients have a hard time staying on their medications. We make it too difficult. So when we talk about this context of where we're headed in 2030, what can we do? Well, we think building a better pharmacy experience is one thing that we can actually do to protect our broader health system, to protect the four walls of a hospital, to help people stay on their medications. So I'll be talking to you a little bit about some of the innovations we've been launching here in 2023. The other piece here is virtualizing test to treat. That's that bucket here on the bottom left. We've now entered a space where before long, and if you're hailing here from Western Europe, you might already have some of these tools or are very familiar with these tools. Tests in the at-home environment that can test for COVID, flu, RSV, they are already available in parts of the world, like Western Europe. Hopefully before long in the United States. We have, in our healthcare portfolio, devices like Alexa that can allow for an iterative dialogue with a patient. Patient says something's wrong, well, perhaps we can actually get them the help that they need through voice. We're entering a world here that patients now are more empowered with telehealth tools right at their fingertips, but better diagnostics. Pharmacy matters. It's the back end of a holistic end-to-end care experience, but you need diagnostics, you need useful triage points up front to make that end-to-end virtual at-home care experience actually meaningful. Patient needs to know what's happening with them. Is it COVID, is it flu, is it RSV? Is their A1C too high? The better devices we actually have in the at-home environment, pairing that with a telehealth consult and with an at-home pharmacy delivery experience that is revolutionary, that to me is transformative change. That's what we're aiming for. I know that's what many of you are working towards. This is not just a one-company approach. I know multiple health systems across the United States. I know the University of Colorado, University of Pittsburgh. We have a few representatives across the spectrum here from highly regarded health institutions in the United States. All of your institutions are working on similar efforts as well. This is where we're all headed, a holistic end-to-end care experience. So pharmacy, Amazon Pharmacy. We talk so much about customer centricity at Amazon more broadly. How are we applying those teachings to what we're doing in pharmacy? Well, I'll say it starts and ends at price transparency. I can't tell you how many times as a lung doc, I have somebody come to me for care and say, you know what, doc, I need my Advair. I need my albuterol. Can you send that script into the local pharmacy? And they then come back to me and say, I went to the retail pharmacy counter and the price was too expensive. At least in the United States, we have a system largely at scale where you're prescribed a medication and you do not know how much you're going to pay for it until the moment you step at the pharmacy counter. So we're trying to change that, both for branded medications and also for generics. We've launched a feature set I'll talk to you about shortly, coupons on Amazon Pharmacy, where if there's a coupon that exists from a manufacturer, we're not going to expect the patient to download a lot of information, go navigate a ton of paperwork to figure out, well, gosh, how can I get the bottom line cost for, say, a branded inhaler or a weight loss drug or an insulin product? No, we're going to automate that process, have it fully behind the scenes to make sure that patients get the lowest price possible in the checkout counter. Why does that matter? You might be wondering, well, doesn't that already happen now? Why is he even talking about this? No, it turns out that 85% of the time in the United States that a medication is prescribed for which a coupon exists, 85% of the time that coupon goes unapplied. It's a big deal. We talk about price transparency all the time in healthcare. We're actually trying to do something about it. Direct-to-doorstep delivery, 24/7 clinical pharmacy support. When I prescribe, I don't expect to have a pharmacist available 24/7, 365 to walk my patients through a question they may have. Maybe it's a side effect. Maybe they need a next best alternative because their medication is too expensive. To now know that we actually have a care team here that can be part of a holistic care experience, accessible 24/7, 365, to me, that's an incremental step forward. That's not something that I'm used to, my colleagues are used to in clinical practice, at least in the US. It's a big shift. And why does this all matter? 30 versus 90-day supply, automating refills for those that might be on a chronic medication. Moving from 30 to 90-day supply if it's clinically indicated. Packets for those with polychronic conditions. I'm talking to you, all of you, experts in this space. None of these things are novel. We're not the only ones doing some of these services. But when you couple it with true transparency at the point of purchase, when you couple it with 24/7, 365 clinical pharmacy support, to us, we think we're moving the needle in totality on an issue that is vexing, which is medication non-adherence. It's simply too hard to navigate this process right now across the 50 states in the United States. And so in totality, yes, each one of those individual services, you may say, well, gosh, I know 10 pharmacies that are trying to do that. Or I know the health system across the streets actually trying to work on 30 versus 90-day and optimizing patients to be on 90. Well, it turns out there's a lot of room for improvement. I will lastly say, before I actually move on, for those who haven't seen it yet, this is a seminal study, Annals of Internal Medicine, published about a month ago, Annals of Internal Medicine. You can look it up. It was a study done by the pharmacists at the University of Toledo. And what it found was that GoodRx, or our prescription savings program, PrimeRx, if they were utilized at scale, if more people knew that these programs existed to save patients time and money, almost $1 billion would be saved on the purchase of some of the most commonly prescribed generic medications. This is a study published in Annals of Internal Medicine on the underutilization of discount cards provided by mail-order pharmacies like ours that, frankly, will save more money often than copays that people pay after their insurance is applied. This is an issue of utilization. It's an issue of awareness. Frankly, many of my clinical colleagues do not know right now that Amazon even has a pharmacy, that we have all these services, that we're trying to drive down the cost of insulin to the bottom line cost, $35 a month, as stipulated by Congress, that we're making that easy. There's a lot of gap in awareness here, and we're trying to close out. What can you expect? I'm not going to spend a ton of time on this because I think this is experiential, and I wish I could show you this. But it's easy. If you're a patient here that says, you know what, gosh, I want doorstep delivery of medications, you go, you establish a profile at pharmacy.amazon.com, you input your insurance information, what medications you might be on, very easy to do, and who's your prescriber, and we'll fetch the prescription. What I like about what we're doing, in addition to the fact that I think in totality I oversee a team of clinical pharmacists who are actually working with patients with polychronic conditions, saying, you know what, you need to be on 90 days. We think it will actually help you stay on your medications. It'll save you money. Well, let's get you on packets. In addition to the core feature set that I think is actually going to move the needle on medication non-adherence, better clinical outcomes, real impact. We're not just talking about disruption for disruption's sake, we're talking about clinical impact. Again, protecting the ICUs, protecting emergency rooms across the country, supply-demand imbalance, that thesis that we started out with early on in the beginning of this talk. How do we keep people healthy and out of traditional healthcare facilities? Well, I think we have that core feature set, and we're building on it. But this is what this looks like in real time, the holistic end-to-end care experience. We're more than just a pharmacy at Amazon Health. We launched Amazon Clinic, 50 states now, synchronous, asynchronous telemedicine. Multiple conditions are now serviced and provided through Amazon Clinic. It's a marketplace for third-party telehealth providers to provide their services at the lowest cost possible. Often the fee that you will pay on Amazon Clinic is going to be less than your copay to get seen for a condition like, say, flu. Or if you're having sniffles and you say, you know, gosh, I think I might have an infection, the copay or the fee you'll pay to get seen by a provider through Amazon Clinic often is less than the copay from your insurance. But what is it doing? In a world where the Commonwealth Fund in the United States says 1 in 2 adults across the United States does not have access to same-day or next-day primary care services when they're acutely ill. Let me repeat that. Commonwealth Fund, right before the pandemic, found that 1 in 2 American adults did not have access to same-day or next-day care when they were acutely sick. So virtualcare.amazon.com, we believe, coupled with One Medical, our other primary care offering, is helping to fill that gap. In partnership, of course, with so many other virtual telemedicine offerings that are happening across the spectrum in the US, across the world, we think we're filling an access gap at the lowest cost possible. But what are we seeing here? I'm showing you the case of a COVID-19 care journey. You answer a few questions. We determine if you're eligible potentially for a treatment like Paxlovid. And then what happens? If you choose to want to have medication delivered to you via mail order, it's an option. You don't have to. You can have that experience through pharmacy. Well, we're going to guarantee you price transparency on checkout. We'll let you know when that medication is going to be delivered to your home. End-to-end holistic care, virtual test to treat. So what are the innovations? What I just described to you, what I've been going on and on about, might sound at every step of the way, well, what they're doing, that isn't transformative. That feels incremental. And you'd be right. I think every step of what I just described here is stepwise incremental change. But in totality, it's a paradigm shift. In totality, every step of the way, we're trying to innovate. We're trying to make every step easy. Patient-empowered triage. By the way, that HPI, the history of present illness, that is output from answering a few questions through your virtual care experience on Amazon Clinic, that actually auto-populates a note for a provider. At a time when provider burnout is as high as ever, we're streamlining documentation requirements, making sure that they're compliant. Pharmacy choice, if you want it delivered right to your doorstep, we'll provide that with a delivery time. Clear price transparency, again, we're not just talking about it, we're delivering on it. Promise time, especially for acute medications. In totality, again, at least from what I saw as a pulmonologist, this is not the care experience that many of my patients experienced throughout the height of COVID-19. They had a hustle to make an appointment, to get tested, to get a triage point through the traditional four walls of healthcare. It wasn't patient-empowered at all. It was still very much provider-dependent. When it came to getting a script rendered, right now can happen within 2 minutes if you're appropriately eligible for something like Tamiflu or Paxlovid when time to treatment really matters. 2 years ago, that wasn't the case. It's hard to get a prescription. It's even harder to actually want to go into the pharmacy counter, pick up a medication if you're acutely sick. We are changing this alongside many of you. Virtual test to treat protects emergency rooms, protects ICUs. And that's something that we're trying to grow over more conditions, over time, in more parts of the United States as we get faster delivery speeds. And hopefully, we can have a broader discussion over time about what this could look like in more places just outside of the United States. I'm going to spend my last few minutes here on some of the services that we're focused on that are not just about test to treat. The value that we think that we're connoting to those with chronic disease. This is a program some of you might have heard of, RxPass, launched in January. And part of the motivation of this program was, well, gosh, it is complicated enough for patients to have to navigate individual copays, especially if there are multiple medications for hypertension, high cholesterol. How do we streamline that experience? How do we create a formulary set and a program that is going to provide disproportionate value to the 150 million Americans that have chronic disease? So we created a formulary that has antihypertensives, cholesterol pills, some diabetes medications. And we launched RxPass, $5 a month as an add-on if you're a Prime member. Free delivery at home. And the intention here is that care paradigms, like combination therapy for hypertension, needing 2 medications up front early on in the course of your high blood pressure journey, that's indicated now. That we want to start people on 2 medications up front early because that means better clinical outcomes down the road. Well, how do we make that as cost-effective as possible? So we launched this low-cost program. Turns out patients thought it was engaging. They understood it. It made sense. It was convenient. It was filling the white space. This was not complicated. We just felt like we could add value in a space that is needlessly complex. Happy to answer more questions on that during the panel discussion. I'm going to wrap up here in the next few minutes. But this, to me, solves a problem that we don't talk enough about. Coupons on pharmacy. You might say, well, gosh, that doesn't even sound transformative. What are you talking about? What is coupons on pharmacy? Too often, we operate in a space, when it comes as prescribers, I'll say this, where we're prescribing medications that are very expensive for the patient, for which copays don't durably bring down the cost of that medication, but for which, again, a coupon exists from a manufacturer that often goes unapplied. So about a month and a half ago, we launched insulin coupons on pharmacy. 15 insulin medications supported by manufacturers like Eli Lilly and Novo Nordisk, amongst others, in addition to 3 continuous glucose monitoring devices. So 18 diabetes products. And what do? Some of you might have seen some of the discussion in the United States in the aftermath of Congress saying nobody should have to pay more than $35 a month, regardless of their insurance, for an insulin product. And this is specifically for folks that are on Medicare. What we found was, and two of our senators actually issued a report, that despite that legislation, despite that activity from the legislative level, there was still too much information asymmetry. People were still not benefiting from that $35 a month cap on their insulin products because it was still too expensive. They still had to navigate a complex bureaucracy of paperwork to actually get that bottom line cost if they were eligible for that $35 out-of-pocket maximum. So we're trying to streamline that. In classic fashion for our company, at least, we're trying to automate whatever we can for the patient. No downloading forms on a manufacturer's website, no having to go navigate to a third-party website to figure out how much an insulin product costs, where to get the lowest cost. We're going to provide that. And so we're growing this program over time. We have some pulmonary inhalers on it. We have weight loss medications, 18 insulin products, or 18 diabetes products, 15 insulin. Over time, providers are also seeing, well, gosh, I didn't even realize this problem existed. When I say the 85% number, that was actually a Massachusetts Department of Health study in 2018, that 85% of the time a manufactured coupon exists, it goes unapplied. When a medication for which a coupon actually exists is prescribed. 85% of the time, patients lose out on cost savings. It's incredible. It is incredible the amount of opportunity there is to actually drive value for patients. Lower costs, improve cost-related medication non-adherence, make it simpler. So we're focused on that. I'm going to close here with a comment on patient engagement and then trust. And then I look forward to our panel discussion. I would argue that the biggest driver of ill health and mortality in the United States, at least, what I know well, is poor patient engagement. This is what Health Affairs, the leading health policy journal in the United States, actually characterized back in 2013. That those that are the least engaged in their healthcare actually cost the healthcare system 20% increased costs because they're less engaged. They're not following up as much. They're not taking their medication on time. They're not getting the refills. Because bottom line, it's too darn tough. Poor patient engagement. When we think what our driving North Star at Amazon Health is, whether it's Amazon Clinic, making it easy to get access, to solve for some of the problems that the Commonwealth Fund characterized back right before the pandemic on access when you're acutely sick. One Medical working on some of those same issues. Or pharmacy, trying to reinvent a pharmacy experience that actually promotes medication adherence at the lowest cost possible. When we think about the problems that we're trying to solve at Amazon Health, it's this problem. Poor patient engagement. It's the reason why in 1990, the leading cause for ill health and disability worldwide, according to the University of Washington, was high blood pressure. And now sitting here in 2023 here in Brisbane, the leading cause worldwide for ill health and disability is high blood pressure. Right below that, diabetes. Right below that, high cholesterol. The three leading risk factors for ill health and disability in 1990 are the exact same here in 2023. Relatively speaking, we have not made progress because, in my view, and this is where we can have a discussion, poor patient engagement, driving a lot of that. I'm going to close by just talking about something that's near and dear to my heart. I spent a lot of time just in public communication for US-based media. One thing that really struck me is our solution, at least the solution I'm proposing, in concert with many of our partners, in concert with many of you, is digital is the only way forward. Expanding scope of practice for pharmacists, critical. We have to have a thoughtful discussion there. Otherwise, we're going to be deploying the military in 2030, and that's not going to work. But part of what I just described to you, Amazon Clinic, a better pharmacy experience at home, part of what that means is patients are going to take more ownership of their care. And we think we're meeting the moment by actually providing services because they want that. They want more ownership. They want patient-empowered triage. They want their pharmacy experience right at home. However, as we make healthcare a little bit more distant from direct provider-patient interaction within the four walls of a traditional healthcare setting, where trust is often built and nurtured, I think we all have to keep in mind here some of the dynamics we've been all facing over the last 4 years. Trust in healthcare institutions is not high. Digitization of healthcare, to me at this moment, needs to be handled very sensitively. I get questions from my patients all the time. Hey, doc, can I trust what I'm getting from this telehealth provider, whether it's ours, whether it's the big health system down the street? Or, hey, doc, are there clinical folks working at Amazon Pharmacy who's actually making sure that the meds that are dispensed are safe, that they're checking drug-drug interactions? Turns out we have an excellent clinical pharmacy team doing all those things and more. But there's those questions that are being asked. As we're making it easier to get healthcare services in the at-home environment, at this moment, when trust in healthcare has been injured over the last 4 years, I think we have to keep in mind here, patient trust, nurturing that trust, ensuring that they know that everything that's being put out in the digital ecosystem that we stand by is clinically excellent, that there's no gap between what we're providing in the virtual domain and what they could get in terms of healthcare services within the four walls of a hospital. I think we cannot lose sight of that and constantly message and provide reassurance. So with that, I really look forward to the panel discussion, but thank you for your time.
Well, thank you, Dr. Gupta, for getting us off to a great start here and thinking in a new paradigm, and of course, applying technology to healthcare and improving health for all. So it's my privilege to introduce our next session, which is Rwanda's Way to Digital Transformation, a country case study in action. Now, I learned a short while ago, and maybe many of you know, but Rwanda is in the top 10% of countries in the implementation of digital transformation in health. So I'm going to have our speakers introduce themselves, and I really look forward to the innovations that you're going to talk to us about.
Thank you. My name is Dr. John Nyirigira. I'm from Rwanda. I'm here on behalf of National Rwanda Pharmacy Council. I'm here also with a colleague, is a registrar with the council. But as well, I'm also from the academia. I'm the lecturer in the University of Rwanda, in School of Medicine and Pharmacy, and also work with University of Mount Kigali as a DVC in charge of administration. Okay, thank you very much. I'm very happy to be here, and I'm going to share with you the experience of Rwanda. First of all, there's no, of course, there's no conflict of interest. Yeah. So my presentation, of course, covers 6 areas. I'm going to give you an introduction. And also, I take you through the Rwanda digital transformation journey. And also, I take you through the Rwanda digital transformation in healthcare service. And also, I take you through the government initiatives. And also, I talk about the challenges, opportunities, and lastly, I conclude. Of course, I know some of you have not been in Rwanda. You hear about Rwanda. So Rwanda is a country that is located in East Africa, and we border almost 4 countries. That is, in north we have Uganda, south we have Burundi, west we have Congo, that is the Democratic Republic of Congo, and the west northern we have Uganda. The population, according to 2022 census, we have a population of 13,246,394. The area of our country is 26,338 square kilometers. The life expectancy is 69.6 years. That is the average life expectancy of a Rwandan to live. The official language, our official language is, we have Kinyarwanda, of course, which is the national language, and we also speak English and French. We use French as a currency, and we belong to the following membership: UN, African Union, East African Community, World Health Organization, Commonwealth of Nations, and also we belong to the Organisation Internationale de la Francophonie. Now, the success of our digital transformation, of course, is anchored on Rwandan Vision 2050, of course, which aims to transform the economy and modernize the lives of all Rwandans. Now, this vision is also anchored on the good foundation of ICT. So for good foundation of ICT is one of our enablers to succeed to this digital transformation. Rwanda, of course, as a country, to be able to succeed to digitalize the whole country, we embraced ICT as the engine for Rwanda knowledge-based economy. And the whole country is, of course, there's digital transformation in all sectors. Of course, there is, as you can see, the digitalization is across all sectors, in governance, in health, in education, in agriculture, trade, industry, justice, finance, and also private sector. And of course, as currently, Rwanda also aspires to become a regional innovation hub, and we have already started the journey where we have a Smart Rwanda master plan. Rwanda digital transformation journey, of course, started some time back. It is not something that has started soon. As you are aware, we experienced a genocide against Tutsi almost 20 years, more than 20 years from now. So we started this journey almost from zero, and we started around 2000. And when we started the journey, the government of Rwanda put, of course, set a vision, which was by that time Vision 2020, and the Vision 2020 was broken into 4 components, and the 4 components, each component was focusing on specific activities. The component, of course, we call it National Information Communication Infrastructure Strategy. And the NIC one, of course, was focusing on policy development and putting up the institutions in place that are overseeing digitalization. Then the second component was overseeing the ICT infrastructure development, where, of course, the government had to roll out the fiber optics, of course, which is the backbone of the success of this digitalization. And then the NIC 3, of course, which was the study phase, was to roll out now the services online, and again also to put some other, like cybersecurity and also the database centers. And then NIC 4, which of course where we have reached, we call it Smart Rwanda, and this is the where now the government is now, there is mass digitalization, and also there's also a lot of innovations that are happening now. Specifically now, let us go to health. Now, Rwanda digital health transformation, of course, in the health sector. So as our success, of course, health sector, so digitalization is under the Ministry of ICT and Innovation, and from under the Ministry of ICT and Innovation, we have the Ministry of Health, and in the Ministry of Health, we have the office, a digital office, and of course, this is in the Ministry of Health, but also in the other ministries also have the digital offices, but specifically now in the Ministry of Health, this digital office is overseeing the applications of health, the health applications, the governance, and also oversee the infrastructure that is under the Ministry of Health, and also it oversees also the data standards. So now, this is the structure of our health sector. So our health sector, we have the referral hospitals, we have the provincial hospitals, we have the district hospitals, we have the health centers, we have the health posts, and also we have the community health workers. Most of the diseases in our country, of course, are being managed right away from the community health workers up to the health centers. Of course, when there are complicated diseases, of course, are referred to the higher level hospitals. The digital transformation now in health services. So Rwanda Health System embrace digital technology in service delivery. Of course, we do this inclusion of electronic health records, telemedicine, mobile. There's also mobile health apps. There's also the use of health information exchange, and also there's the utilization of health care services that facilitate the better communication between health care providers and also efficiency of service delivery. So within the digital health system, pharmacists have emerged as the key players in optimizing patient care and also the efficient management. Again, here, specifically now, when we go to pharmacy sector, of course, pharmacy sector also is under health. So we have Rwanda Food and Drug Authority. In Rwanda Food and Drug Authority, of course, different services that are being offered there, they are all digitized. Let's say if you want to register drugs, if you want to, as a pharmacist, you want to get the license, or if you want to put up, you want to establish a pharmacy, or if you want to get the good manufacturing services, also you want to, the clinical trials. So all the services in this institution are all digitalized. And in Rwanda FDA, almost 80% the services are offered by pharmacists. Also, we have another government initiative we call Rwanda Medical Supply. In the Rwanda Medical Supply, of course, this is like a central medical store that supplies the medicine within the country. It is government managed, and the services are also which are offered here. They're online, and they use a system called Electronic Logistic Management Information System. And this system, of course, offers the inventory tracking, order management, data analytics, quality control, real-time communication, improve the data visibility, and also efficient supply chain management. And also in this central medical store, most of the services are online and are managed by pharmacists. There is Ilembo, what you call Ilembo platform. This is a platform. This is a government-initiated platform, and it started in 2015. And most of the government services, all the services offered to the citizens in Rwanda are offered through this platform. So more than 100 services are offered through this platform, and almost every day around between 3 to 4 million services to citizens are offered. We also have another public-private partner called Zipline. This Zipline, it is a drone-based which delivers blood, vaccines, and the medical supplies, especially to those remote areas, of course, where there is geographical barriers, and also there is an efficiency in delivering of vaccines and blood in a time, because that's where, of course, other means cannot reach, and they are delivered by the drones. Also, in this digitization, of course, process, we also have the academic institutions that they are in place, of course, to help or to participate in developing the human capital, and of course, who are going to accelerate this digitization space. We also have another private sector initiative called Babil. This Babil, what it does, patients does their consultation online, and of course, patient can use a phone. There's a code they use. They can call, and they get consultation. They are given the lab test online. They can go to the paternal lab. They do some tests, and then after that, the results are sent back to the Babil, and the Babil can do so you can prescribe medicines, and then the patients can be given sent to the pharmacies that partner with Babil, and then they can get medicine. And when, of course, some cases are complicated, the Babil can be able to refer them to the higher or to the other hospitals where they can be treated. Again, also in Babil, of course, pharmacists they are part of it because they participate in influencing in the prescribing of medicines. And also when the patients go to the pharmacies, they are served by pharmacists. There's also we have also another private sector. We use Ishiga system. This Ishiga system, it is commonly used in Rwanda, in community pharmacies and also in wholesalers. And again, this Ishiga system, it interoperates with the government health management information system and also the tax system, whereby, of course, this system, it does the stock and sales management, automation of prescription management, the billing, the insurance management, the tax management, stock management, and of course, as I said, it is mainly used in the community pharmacies and the wholesale pharmacies. Of course, in this digitization process, of course, we also encounter challenges, and also we have the opportunities. In the challenges, of course, there's digital literacy, whereby the proportion of the population in Rwanda still lacks the necessary skills to effectively use these digital technologies. And also, there is the language barriers. Of course, you find most of these technologies we are using, of course, we use English, and you find, of course, a number of the locals, they can't speak English, they speak the local language, so it is also another challenge. There's also, of course, cybersecurity and private concerns, of course, I mean, not only in Rwanda, also across the world. There's also limited financial resources. In opportunities, the government investment has invested in digital infrastructure, expanding internet connectivity with initiatives like the National Fiber Optic Backbone Network, and also there's government support for startups and innovation, and also there's government commitment to partnerships and also the collaboration. Again, also another opportunity, there's a broadband for all and digital literacy for all by 2024. There's also digital literacy initiatives, and also we have what you call the digital ambassadors who move around in communities, of course, educating them how to use these digital technologies. In conclusion, of course, Rwanda embraced the ICT as the engine of for economic growth across the whole sectors. And also, there is a target to achieve 100% of digitization by 2024 by digitizing the remaining services. As I said, of course, it is ongoing. It is an ongoing process. We are still digitizing, but at least a number of services now are online. So there's also to conduct digital literacy for citizens, targeting almost 80 million by 2024 for access to information and also e-services. Also, there is a political will to continue digitizing all services throughout the country. Thank you very much. Merci beaucoup. Asante sana. Murakoze cyane. Thank you for listening. Thank you.
So this is not a paid advertisement, but I had the good fortune of going to a conference in Rwanda just prior to the pandemic. And if any of you ever have the opportunity to visit Rwanda, you should really do that. And you saw the picture of the mountain gorillas. It's a transforming life experience to take that journey. So it's now my pleasure to introduce our last speaker, Professor Chris Bain. 2019 apparently was a big year for me because I met Chris Bain in 2019 at a conference just prior to the pandemic and was immediately impressed with the insights he had in information science and digital health. So I did what, I'm the dean of the University of Colorado, so I did what a dean should do, and I said, you have to come and visit us, talk to us about all of this, which he did. He came and visited with us today, back in 2019. So I consider it, and I was very impressed with what he had done with our faculty, and so I'm very fortunate that he's able to join us today. So he earned his Bachelor of Medicine degree in 1990, a Master of Information Technology in 2001, and a PhD in Information Systems in 2014. He is obviously a lifelong learner. He's the inaugural professor of practice in digital health at Monash University in the Faculty of Information Technology. He has more than 30 years' experience in the health industry, including 12 in clinical medicine. He has led numerous software development and implementation projects in clinical and management support areas, resulting in a range of prototype and fully implemented systems. And a large part of his work involves helping to drive Monash University's initiatives in digital health, working in collaboration with other faculties, a range of Monash institutes, and various external partners. His current roles include lead for the Alliance for Digital Health at Monash, co-director of the AIM for Health Lab, professor of practice in digital health in the Faculty of Information Technology, and an adjunct professor in the subfaculty of Translational Medicine and Public Health, and the Australian lead for NEED, which is the Network for Equity through Digital Health. So please welcome Professor Chris Bain.
So a note to self is when the organisers ask me to give you a bio, I won't give them a reused one, I'll give them a briefer one next time. Thank you very much, Ralph, for having me. It's 4 years since we met, which I can't quite believe, but we've had that interesting thing called the pandemic in the meantime. I won't talk any more about my background. You've had a good experience of that through Ralph just now, and I'll try and move quickly because we want to have some chat in our panel session at the end. And I believe from what I heard earlier, you'll get access to these slides at a later point, lots of references on the slide, so I won't dwell on those. We're going to look at the intersection of digital health and precision. I always start talking about digital health. We're trying to set the scene for what I think it is, because it's covering a multitude of sins, especially at the minute, but increasingly we'll get more precise. And also look at this topic of precision at different points in the medicine's development life cycle. So this is a really simple definition I like to use because it covers our current reality. So back at home, and welcome to Australia, by the way, for those who are new to our country. It's really great to have people come and visit us. Back in my state in Melbourne in the south of Australia, we still have active conversations about really basic things like clinical information systems and electronic medical records. So my last hospital job, they were still working on paper, albeit that's getting on 6 years ago. But at the same time, we have people in our country and all around the world doing some very, very innovative, cutting-edge stuff. And that all is included in a conversation about digital health. But what I'd encourage you to focus on for this talk is those 6 points there. I can't expand on them due to the lack of time, but you'll see them come to life in some of the examples I'll talk about. Smartphones are critical. The apps we deploy on smartphones are critical. Measuring things about the human body or about human behaviour and turning them into ones and zeros, which is basically what digital biomarkers is. Sensors let us measure stuff. Your mobile phone has sensors in it. Camera, microphone. You can plug sensors into your mobile phone. And there are increasing range of sensors and biomarkers. Augmented intelligence, so the idea of augmenting human performance. Doctors, nurses, pharmacists, patients, carers. Sometimes that's through artificial intelligence and sometimes that's through other kinds of technology. So I prefer to talk about that than AI. In the traditional sense where we can. And patient empowerment, you'll see threads back to Vin's talk, threads back to some of the talk from Rwanda as well. Digital health is both driven by a need for greater patient empowerment and delivers greater patient empowerment. If any of you don't know of a thing called Open Notes, for instance, I'd encourage you to look it up. One example of how patients are being empowered through digital health. Precision, so we're talking about being exact. And I'm going to take a bit of a liberty with that definition as we talk about this. So what we're looking at is, can digital health and AI, we do have to pay some attention to AI, bow at the altar of AI a little bit. Can it have a role in supporting precision or exactness, both in outcomes in these different stages of the drug process, the medicines process, but also in how quickly we can get to answers, how quickly we can help people make decisions, how quickly we can get to efficacy, not just exactness of outcome, but exactness of process. So if we briefly stop off at medicines discovery and development, and I was super pleased to see that even today, there are spin-offs that relate to these topics. So it's too brief to be able to really delve into them with you today, but there are sessions today on digital therapeutics, on the role of informatics and informatics pharmacists, and on AI and drug discovery, so please take advantage of those sessions. This is a 2023 paper. It's not the best grammar, but it's got some interesting stuff in it, so I've pulled it out. So as you would all know, the journey from conceptualising a drug to its eventual implementation is long and expensive and complex, and we don't do it efficiently. That's just been our history, right? Can we do it more efficiently is the question. And there are multiple parts in the drug development cycle where AI could have a role. So this isn't a talk about AI. AI isn't a single thing. AI is a multitude of things. Machine learning is a big part of AI, but it's not all of AI, and there are multiple kinds of machine learning. What you hear about a lot is about neural networks. So when people from a less educated around AI perspective say, can AI do this? Well, the answer is sort of like, can a computer do this? Well, yes, it can. How good will it be? Wait and see. Do you have the data to do it? That's important. How we frame the questioning for the program is critical. So most problems can be looked at from that lens. It doesn't mean it's the right way to approach the problem. Again, not great from that first paper, not great grammar, but interesting little graph just to point to the fact that in many parts of the world, AI and drug discovery is a hot topic. It's predominantly in the US and Europe and Canada and the UK, but when you look at pharma corporations and tech companies getting into the space, separate of startups or contract research organisations, and those things are off to the right, then Asia starts to come into the fore with the green bar, but most commonly this stuff's coming out of the US and the Northern Hemisphere. An example from our own university. So as you would all know, we have a massive faculty of pharmacy and pharmaceutical sciences at Monash. Monash is really a global university. It's through that faculty that I got to meet Ralph in our Prato facility. They do a lot of work, obviously, in medicines development and have started to work with us more at the AI end. So this is a paper recently published this year involving Dr. Lauren May from that faculty and our own Professor Jeff Webb, looking at can we use AI to accelerate G protein coupled receptor drug discovery, and they've highlighted a number of phases of the process and a number of subtopics within each phase where AI could be used. So as I said before, could it be used? Yes. Will it help? Time will tell. It's critical to really phrase, though, what it is you're trying to find. Okay. So I just wanted to highlight that for you. Jeff is the highest ranked by a recent survey comp biology, bioinformatics researcher in the Asia Pacific region. So he's one of the people who leads the AI end of this conversation with our pharmacy colleagues. Some of you will be aware of this. I thought this was interesting. This was from earlier this year. So the first AI created drug not only created the design but also discovered the target, has gone into clinical trials, and it's in a needed area. So it's targeting idiopathic pulmonary fibrosis. And there's not a lot of drug therapy in the space. So quite interesting as to what's possible. There are plenty of other drugs that have been discovered, a handful at least that I'm aware of, that are in this early stage. But this is the first one where AI had a role in two parts of the process. So now we're going to switch into safe and effective prescribing of medicines. This is more my space. So I work sort of in this intersection agenda with Jeff, but I'm less the AI expert and more how do we impact the real world? If you've got an AI model, how do we actually deploy it? Is it valuable? Who does it help? How does it fit in the workflow? But also in a whole bunch of other spaces that we'll touch on now, where we're trying to look at how can we use software to actually help the workflows of pharmacists and clinicians, but also help patients and their carers. So this is talking about a new paradigm. It's talking about EMRs here. It could be talking about absolutely pharmacists' use of EMRs, but it could equally be talking about pharmacist-specific systems. And the picture we're trying to create for you here is often these systems, these big corporate systems, are very rigid. They've been designed on standardisation. And we know that butts up against the increasingly specialised world of healthcare. So even an orthopaedic surgeon is no longer just an orthopaedic surgeon. They're a hip person, a knee person, a shoulder person. This paradigm that's being pictorially represented here is showing how we can now develop subsections, if you think of them as apps, to plug inside these concrete systems to tailor what you do as a unique specialist in your area. If the system can be built, it can be plugged into these bigger corporate systems. This whole paradigm is called Smart on Fire. Many of you won't have heard of it. The fire part is about standardising micro-level healthcare data, so down to the genetic profile in some cases, but even, for instance, the individual finger prick reading taken on me at 2:30 last Wednesday by Nurse Jones in the Alfred Hospital. Okay. And that standardised information approach allows us to share things. The smart bit is sort of the container, if you like, where these apps are then put inside electronic medical records. This one isn't a pharmacy example, but I wanted to highlight to you. So a wound tracking app that takes a picture of a wound, sends it to a machine learning model that shows how much healing is going on, and then pictorially overlays it over the wound. Okay. So you can use it outside of an EMR or within the confines of an EMR. And equally, these smart apps, so there's a thing called the Smart App Gallery, which you can easily find on Google, has a whole bunch of apps targeted around medicines and their use. Okay, and I'm going to drill into a couple of these. Who's heard of DoseMe? Can I have a hands up? So still not many people in a pharmacy-specific audience. Okay, an Australian product, bought up, run out of the US now. Think of vancomycin, think of warfarin, does this for several dozen drugs now. Complicated dosing decisions dependent on pharmacokinetics, previous doses, renal function, etc. Uses an approach called a Bayesian approach to predict what the next dose should be. So really unique stuff. You'll have to trust me that it works. There's plenty of evidence on the web and in published research about this. Little example here, this study in the British Journal of Pharmacology, 9-month prospective study looking at using vancomycin in a vascular ward, looking at did DoseMe as a tool help or not, basically, and used a retrospective control group. Looked at outcomes, clinical outcomes, including kidney injury, obviously, but also what was the mean AUC over 24 hours within an acceptable range, and the percentage time of the drug in acceptable range. On both metrics, it did well. It did better than the historic cohort, and in some cases, nearly twice as good. So in terms of percentage time therapeutic range, twice as good as what was historically done without the use of DoseMe. So lots of papers around this. Feel free to go and chase those up. This is a opioid prescribing guidance system, I think quite specific to the US. An example of one of those smart apps. So it pulls in known history of drug usage by particular people off a central registry and then helps guide the next decision the prescriber or the administrator of the drugs is about to make when it comes to opioids, trying to deal with the problem of opioid abuse. Open source app, which is great. Now we're going to look at precision in the safe and ongoing use of medicines. Clearly these two things can blur. Some of those things I showed you can be used in the ongoing use of medicines and monitoring that, but I'm trying to steer you in a slightly different direction here. So the framework we're talking about here, I don't mind this framework, it can be a little misleading. So we're talking about digital health in a macro sense. Within that digital medicine and then entirely within that digital therapeutics, there is a thing called the Digital Therapeutics Alliance, which deals specifically in this stuff. Some digital therapeutics don't use drugs. Some digital therapeutics are centred around drug use. Some digital therapeutics might reduce drug use. So interesting to think of it that way. Some of them are in the behavioural therapy space. They're not about giving you a drug, but they are about giving you a digital intervention, hence my definition at the start, digital tools and interventions. Who's heard of Propeller? Again, not big numbers, really interesting. I often ask this in medical audience, so it's interesting that even the pharmacy audience. Out of the States, it is what you see there. I don't really have time to dwell on it, but the little Bluetooth cap, imagine if you have asthma or COPD, you might have a treater, a SABA, and a preventer, a steroid, and you might have therefore two caps. You register them with the app. Thereafter, the app knows how much drug the patient is taking, what time of day. Don't know for sure. It could probably tell you where on the face of the earth they were when they took it. Can tell you weather patterns in the area, pollen forecasts, can help you record your symptoms. Dozens, at least dozens of papers about this product. Okay, please go and look them up. This little one here, little neat study on asthma and ED. So 220 patients, 1 year before, 1 year post, giving them the Propeller system. Dramatic reduction in ED visits, halved in fact, per 100 patient years, more than halved the combined number of ED and hospitalisation events by using the Propeller system. Interestingly, to the right, less drug use. SABA use reduced by 76%, and a much better profile of prevention to controller as well. So really interesting. Australia is called the asthma capital of the world. If I came to you and there's one study that shows an 80% reduction in asthma attacks, and I said, I can reduce asthma attacks by 80%, and it was a drug, I'd be super rich. Interesting paradigm shift. DNAV, not overly familiar, but I thought it was a neat example, in insulin usage. So computationally guiding somebody in what's the next dose of insulin you should take. This study, a couple of hundred patients, focus on the HbA1c. So monitoring those patients over a 2-year period, 3 times better reduction in HbA1c than not using the system. So impressive stuff, can't really ignore it, especially when it's one of multiple papers and multiple bits of evidence. This might seem like Star Trek, but I think this is really interesting. This pushes the whole digital biomarker sensor thing. So this is looking at the problem of opioid overdose, which we know can be from prescribed drugs or illicit drugs. Interesting little proof of concept study using the mobile phone as a sonar system. So issuing an inaudible sound from the microphone, bouncing it off the chest of a person and capturing it in the microphone. Basically watching the chest rise and fall using sound waves. They trialled it prospectively in a safe injecting facility, and they tried it in the OR, where we induce an opioid overdose in some patients to put them to sleep. Really impressive results at measuring respiratory depression or apnea in both those settings. So that's a long way from here at your safe injecting facility, we sign you up to the app, but it's an interesting thing to look at. Shows the whole biomarker idea, the sensor idea. I hope I've trimmed a bit of time off. I feel like I have, a bit hard to tell from up here. Just going to briefly talk. We have the only faculty of IT in the country, in Australia. Everywhere else is a school, often with business or engineering. We're divided into 3 parts: data science, human-centred computing, so visualisation, HCI, virtual reality, augmented reality, digital transformation, and then all the other stuff which is non-data science, technical, networks, IoT, data management, cybersecurity. We have a strong interest in this agenda. This is a modified slide from our pharmacy faculty looking at the different parts of the drug development, medicines development life cycle. We have capability to work in those areas, and we're really interested to hear from people who might be interested in working with us. So thank you for your attention.
Thank you so very much, Chris. I must say it's a very fantastic journey that we are embarking towards the future as pharmacists. And thank you all the speakers as well. Now it's time for the Q&A. So the question is, do we have some question here somewhere around? Here, okay. Say please who you are and who you direct the question.
Yeah, my name's Mark Cosell. I'm from the PDA in the UK. My question is to Dr. Vin Gupta from Amazon. Very interesting analysis of how protecting the ER room becomes the new paradigm. It's all about creating capacity elsewhere in the system. But there are other ways to do this as well. Not instead of, but in addition to. And it's very important to make sure that those other ways of protecting the ER room aren't damaged, because we're focusing on one particular approach. Now, we all know that there are more patients that visit a community pharmacy, for example, than if you were to put all of the other primary care providers together. That's an excellent platform to develop population health models, opportunistic interventions. For example, a patient that comes in with a prescription for an ACE inhibitor, and while the dispensing is being done, asks to purchase some anti-sickness or diarrheal preparations. Well, that's a red flag. We know they have to stop taking those ACE inhibitors for 3 days, otherwise they're going to get acute kidney injury. And in the UK, 150,000 people a year die from AKI. So we have to give them some advice to stop taking the ACE inhibitors for 3 days. That opportunity only exists because they walk into the pharmacy. The gentleman that comes in with his prescription for his hypertension preparation, and we know he's put on 15 kilograms since the last time he was in, because he's twisted his ankle, he can't walk his dog anymore. We have to look at the dose of the hypertension, check the blood pressure, and as prescribing pharmacists increasingly now, we change the dose. These are the sorts of things that can only happen if we have that human intervention with those patients coming into a community pharmacy. So my question to you, Dr. Gupta, is you've demonstrated how very well you can work up a strategy. Is there a way that your strategy can look at the wider network, not just the angle about protecting the ER room, but also collaboratively working with the wider primary care system to strengthen it by working in collaboration and using your excellent platform at Amazon to work in partnership with, say, pharmacy to look after those other routes and systems as well?
Well, I love that question. Thank you for that. And the answer to that is yes. And so we are a lot of, say, Amazon Pharmacy's growth, and I'm sorry that there's such a U.S. centricity to all my comments. That's where we're starting. Our entire growth trajectory has been focused on partnerships with health systems, we're the exclusive mail order provider for several Blue Cross Blue Shield plans across the country. And our hope is, our hope is to get a little bit more integrated with other various health systems across the country as well, whether it's small, medium-sized primary care practice, unrelated to Amazon Health, whether it's clinic or One Medical. It might just be a standalone organization. Whether it's a large health system, we've talked to many who are looking for us to help fill the white space here, because there is not, as you know, there is not 24/7 access to clinical pharmacy expertise. To your point, in-person triage, to be able to put a stethoscope on a patient, to be able to understand what might be happening, to do a volume assessment. I say as a pulmonologist, those things are important. In some cases, those are critical to making an insightful, thoughtful clinical decision. But we can't replicate that in many cases. There's a lot of opportunity here to have some sort of clinical interface, some sort of clinical touch point. But we're working with organizations across the spectrum. And so it's not just how do we keep folks out of the ER, focus solely on individuals who might be coming in through our asynchronous or telemedicine platforms. Very much it's focused on the broader ecosystem, at least starting in the United States. How can we provide continuous chronic management services or MTM services to patients who might be getting their primary care elsewhere? Recognizing that there's only so much we can do physically, and when it comes to actually doing a physical exam, in some cases we're limited there. We still think that there's enormous opportunity to provide that virtual interface with the clinical pharmacists, because in many cases, as we're seeing at least across the United States, pharmacy hours are closing. I'm coming from Seattle, where our last 24/7 pharmacy just closed, or announced that it was closing just a few weeks ago. Access to retail pharmacy experiences, frankly, has never been harder. So that's where I think we have an opportunity. Thank you.
Thank you. Do we have any more questions from the audience? Yeah, we have one question over here.
Hello, my question is for Dr. Jean from Rwanda. I was impressed really for what you have done in Rwanda, but I was wondering, because I have seen the challenges about the language barrier and the digital illiteracy. So I have two questions. The first question is, what are your plans to overcome these challenges in Rwanda? And number two, I'm wondering if you have some statistics about the users of these applications, especially that I noticed that there is a virtual consultation. Why I am asking this, because in Lebanon, because I'm from Lebanon, when we had the COVID, the government has put an application called Impact to register the old patients to have the vaccination. But they forgot that these old, very old, because the first group was 75 and above, they are not really at ease using the. So they ended by having the lowest number first of registered person, and we in the pharmacy, we were doing the job of these people. So sometimes you have to know exactly what the community's needs and what we can do before putting very sophisticated, or maybe it's not so sophisticated applications and digital solution. So if you can answer this question, thank you very much.
Okay, thank you very much. Yeah, of course, one of the barriers, of course, I've talked about is, of course, is literacy, digital literacy, and also, yeah, digital literacy is one of them. Of course, okay, the way to overcome the digital literacy now, what the government is doing, under the Ministry of ICT and Innovation, of course, they have put in place some people they call digital ambassadors. Digital ambassadors, so those are the younger people, they have already mobilized, and they go deep in the villages to educate people so that now they can analyze the knowledge on digital, the use of these devices. And again, of course, as you said, of course, we have also the aged population, of course, who cannot understand maybe maybe English because they use the Kinyarwanda as local language. But the bigger population also, because in our country, 70% are youth. 70% are youth. So that one, of course, it is, it is very easy to adopt themselves to the use of these digital services because the language is not a barrier. Yeah.
Thank you so very much. Time is running out. We can have one more question, a short question. Claudia?
Hello. Claudia Rijken, the Netherlands. I have a question for Dr. Gupta. Thank you for a very interesting presentation. My question would be, in 2018, I think 2019, there was introduced that there was a medication management module integrated in Alexa. Afterwards, I think it was very promising to help patients via their Alexa device at home. I didn't hear so much more progress in the years thereafter, but just recently, I think some couple of weeks ago, it was introduced that new models of healthcare would become available for Alexa, and I was wondering, is that maybe for pharmaceutical purposes as well? Do you know something about that?
You know, I appreciate the question. I actually came from the Alexa team, the broader devices team in 2022. That's where I spend most of my time. I will say that the Alexa team, and as it's been focusing on the utilization of voice in the at-home environment for healthcare purposes, it's looked a little different over time. I know that they're focused on issues like medication adherence, vocal biomarkers more broadly, but they've undergone a bit of a transition here. And so I can't share anything about their specific roadmap right now, but I can tell you that that's very much something that we're in discussions with them on in terms of, how can we best meet patient needs using voice? I think we all realize it's an untapped opportunity, but it's something that I'd be happy to chat with you more offline as well if that's of interest. So thank you for that question.
Thank you so very much. Well, it's time to finalize or sum up the session. I think that as we embark on this digital journey together, we can now see the opportunities that lie before us, opportunities to amplify the reach of healthcare services, enhance patients' experiences, and also empower healthcare providers with tools that enable precise data-driven decision-making. Of course, we also need to reflect and acknowledge that there are still some barriers to overcome, challenges head-on, and also ensuring that our technological advancements actually are harnessed for the benefit of all, leaving no one behind. But I think that this plenary session has given us ideas and also has the potential to shape policies, strategies, and also collaborative efforts for the future to drive the transformation of health systems and pharmacy as well around the world. So thank you to the audience for being part of this plenary session today, and also let us give a warm hand to all our fantastic speakers for sharing their experience, wisdom, and experience in this very timely and also extremely popular topic. We will hear more about this in the future. Please evaluate the session. Give us your recommendations for what this session should contain in the future at next year's Congress, because by doing that, we actually will create an even more attractive Congress for you. So thank you all so very, very much.